Let me start by thanking the organizers of iPCI for this opportunity. I wish I was there at this meeting, and let me take this opportunity to wish the organizers and the delegates a very, very useful meeting. Now, I'm going to talk to you over the next 10 minutes on the use of non-invasive physiology-based evaluation of coronary lesion. Primarily, I'm going to talk to you about QFR, which is an image-based software solution developed for the functional assessment of coronary artery disease, primarily lesions. And it uses standard angiographic images and eliminates the need for pressure wires and hyperemic agents. Now, if you were to look at the different products that are available, there is the MEDIS QFR, there's CatWorks, there's SPY Medical Imaging VFR, and these are the main players in this space, MEDIS being the one which has been there for the longest period of time and with the largest amount of data. There are other imaging companies that have now come in, so we're going to see over the next few years multiple players in this space. Now, what are the major differences between, say, FFR, IFR versus a QFR? Now, it's not an invasive, it's a non-invasive test. You don't require a hyperemic drug like adenosine. Procedure time is very short, less than 1 minute per vessel. Analysis is possible on multiple vessels during the procedure itself. Cost is much lower because you don't use wires, you don't use drugs, and it shifts workload very little. Actually, it can be integrated into the cath lab so that it can be done virtually in real time. And its accuracy, multiple studies have shown that it's as good as FFR and IFR. So it's non-invasive, it's rapid, it's user-friendly, but more than that, I think these are the two important things that we must remember. It does much more than just FFR-like analysis, and I'll show you some of the things that it can do. And importantly, it can be both retrospective also. So if somebody comes with a CD to you with some lesions which they think is borderline, you can put it into your computer, use the same software, and get the QFR read immediately so that you can make a decision. However, there are some caveats to that. These angios should be done in a certain way to make sure that analysis is passed. Now, when you do a QFR, it uses two standard angiographic projections. Ideally, these are orthogonal with minimal overlap. It then does a 3D modeling of the vessel, and using computational fluid dynamics and AI, it comes up with flow as well as pressure changes and yields a QFR value that virtually mimics FFR. So the workflow steps, you choose the angiographic frames. There is an automated alignment and detection. It's an AI-based software. Does a 3D reconstruction, QFR is calculated, and within about a minute or a minute and a half, you have the results up on your cath lab screen. And this is what it looks like. This is a 3D reconstruction of the vessel. There's a fast flow computational mathematical approach to calculate. And within about a minute, you have a QFR, a vessel QFR. And it does much more than just a vessel QFR, I'll show you in a minute. There are limitations, of course. You need high quality imaging, angiographic images with minimal vessel overlap. And so the company itself will give you the different views that need to be taken for different vessels to make sure that there's no overlap, as well as the orthogonal views are taken. There are problems with ostial bifurcation and graft vessels, and these have not been validated in this subset. Accuracy may be reduced again if there's both severe tortuosity of the vessel or there's arrhythmia, especially atrial fibrillation. So that's a problem. And I think protocol adherence is very important. In terms of clinical accuracy, there's enough data to support this. This is a study actually from FAVOR 2, which is the big studies that MEDIS QFR has done. This is the FAVOR 2 Europe-Japan study, which compared a QFR versus angiography using FFR as a gold standard. And QFR was clearly superior in diagnosing significant lesions versus the usual QCA or eyeballing, with a very high specificity, sensitivity, and the area under the curve being 0.92. QFR versus FFR, and this is a pooled analysis from 16 studies, 2,000, close to 3,000 patients. Again, area under the curve, 94%, showing very, very close correlation between QFR and wire-based FFR. And there's also data QFR versus wire-based IFR, and there's a study again which looked at multiple lesions, 182 patients with IHT and those with MI, and again, area under the curve of 0.95, showing very high correlation between QFR and IFR. In fact, if you look at multiple studies, and these are across the line studies which have compared FFR, QFR, IFR, and the correlation is comparable with all these. There have been multiple studies which have looked at QFR in various clinical situations. I won't go into them in detail, but I can tell you that this is almost as much data that's been produced as in FFR. So this is what a typical case. Now this is an LAD in different two orthogonal views used for analysis. And what is shown here are two lesions, lesion A and lesion B, with a vessel QFR of 0.62. Now, what it also tells you is that if you were to only address, say, for example, lesion A, it will give you a residual QFR, which you will get if you address only lesion A. So here, in this example, you can see that it's a 0.62 QFR. And if you do only lesion A, you will be able to come up to only 0.81, just telling you that both lesions need to be addressed, because what we're trying to do here is to get a post-procedure QFR of about 0.90. What it also does, you can see in this slide here, this is a lesion. It will give you minimal lumen diameter, a reference diameter, and the lesion length. So it's as good as QCA. In fact, we found it better in many circumstances to tell us from which lesion to which point we need to stent. So it helps us in choosing the length of the stent, the size of the stent, as well as the reference diameter. Here again, you can see lesion A in a right coronary. It tells you the vessel QFR is 6.69. And if you were to stent this segment, and the segment is highlighted here, along with the length that you know that you need to pick up a stent, the size of the stent, you will get a residual QFR of 0.92, which is acceptable. Now, it's also important to remember that if you do not get 0.92, there's obviously some problem in terms of the stent being fully open or not, and I'll show you that in another slide. But the usefulness of QFR goes beyond physiology. It's useful for morphological assessment. As I showed you, this is the physiological assessment. You can plan to do a lesion after doing that. But morphologically, it will tell you the length of the lesion, the minimum lumen diameter, the percentage stenosis, the reference diameter, so that you can choose the correct size of the stent. Post-PCI stent optimization and prognostication, I think this is another very important function. There's data to support this. So if you were to look at a pre-procedure QFR here, you can see that the FFR done in this particular patient, 0.75. QFR shows that there are actually three lesions, lesion 1, lesion 2, lesion 3 here, which need to be addressed. You can see that in the diagram here. Now, if you were to do only lesion 1, you would get a residual QFR of 0.82, which is again suboptimal. Lesion 2, 0.86, lesion 3, 0.80. If you do all three, you would get a residual QFR of 0.94. So you can see that the stent that was placed was a long stent covering all three lesions. And this patient, the FFR after PCI was 0.94. And this was what was predicted would be the QFR or FFR, which virtually is very, very closely correlated, was 0.94, and what was got at the end of the stent implantation point. What does it tell you also about long-term prediction? This is from the Hawkeye study, which showed that if you have a QFR at the end of your procedure, of above 0.89 or above 0.9, there's a and it's below that, there's a 3 times higher risk of vessel-oriented maze, and therefore one has to get a QFR at the end of the procedure about this. Now, it can be that the QFR is lower because there is diffuse disease in the vessel, in which case one is sure that what one needs to do is really disease modification medically. But if it's focal, the reason is a problem with stent expansion, one needs to use probably another balloon or a higher size to get a perfect result. It also helps you to assess the disease pattern. So what you can get is the virtual pullback. And using a derivative of this curve, every time there is a 0.025 drop in pressure per millimeter, and this is a 0.020, if it's more than 0.025, you can be sure that there is a significant lesion there. So you can do a virtual pullback, and using the virtual pullback, you can look at the pattern of disease. Is it a focal pattern of disease? If it's focal, from the pre-PCI implication, it tells you what type of stent, what length of stent, what size of stent. And post-PCI, you will get, it will predict what the QFR should be at the end of the procedure. And if you don't get, it tells you that it's a suboptimal result, and you might need to do additional balloon dilatation, or maybe even do an imaging to decide whether there's been some dissection pre or post stent that needs to be tackled. If you have tandem disease pattern, again, the virtual pullback will clearly tell you that, will tell you which lesions need to be addressed, and will tell you the length of the lesion that needs to be addressed. And from the post-PCI, again, it will give you optimization. If, on the other hand, you have a pattern which tells you it's a diffuse disease with no focal lesions, again, it tells you that the disease pattern is diffuse. It's not worth stenting at any point on that vessel, even though the QFR is low. And primarily what you're going to do in a patient like this is to treat them aggressively. Lastly, from the research perspective, one of the very, very exciting areas is in guidance of INOCA and ANOCA. Now we know that CFR or IMR is important in that diagnosis.
Because already we are running out of time, this is an excellent session, and that highlights the imaging, importance of imaging in clinical practice. It is very, very interesting, and we learn a lot of things in the imaging section, newer modalities, especially hybrid and OCT and IVUS in a complex kind of angioplasty, how it is useful, how important it is. So I think we need to always emphasize on the imaging in coronary intervention. So if you want to get a good result, you need to have always imaging. These are fellows course. I think newer generation of the interventional cardiology always, I think, very useful to be familiar with the imaging system. Get imaging, at least one system you can get in the cath lab. Try doing imaging and do angioplasty. That gives a different understanding of the coronary disease, as well as different understanding of the coronary intervention, and you can get a better results. This is very, very important. We should remember that imaging is picking up, and we should also give a lot of training on the imaging system, especially for the young interventional cardiologists.
Okay, thank you.